Encounter is brought to you by the Broome County Council of Churches, where we connect compassion with needs as we inspire growth with dignity. You'll find us in special places throughout the community. For those who remain hungry, we provide meals. For those who are challenged, we build wheelchair ramps. We comfort those who are ill, minister to those who are confined, and we remain an advocate for change and understanding on behalf of every element of our community. Connect and inspire. Encounter the Broome County Council of Churches.
Good morning, I'm Jeff Kellam. Welcome to this edition of Encounter. You know, with the great stewardship of life, God has given us a life that is just full of opportunities and ways to explore, keeping ourselves strong. The stewardship of life in body, mind, and spirit. Keeping yourself strong, for example, in body. Well, maybe it's cycling or walking or going to the gym or just taking a walk down the driveway to get the newspaper when you'd really rather just sit there for a while. Keeping your body going. Mind, reading, deep reading, or puzzling over things, wondering about the universe, working crossword puzzles or trying to figure out politics, ways to keep the mind important, strong in conversation with other people. And spirit, keeping the spirit strong, well, if you're in a community of faith, that's easy. If you're not in a community of faith, then at least every once in a while during the day, stopping, breathing deeply, and wondering at the mystery of it all. Even with all the efforts we go to keep the stewardship of body, mind, and spirit strong and alive, sometimes life, especially as we age, throws us a curve. And for many people, about 1 million people in this country, with about 60,000 per year more being diagnosed with it, Parkinson's disease is one of those things that can throw us a curve. President George H.W. Bush, singer Linda Ronstadt, the baseball player Kirk Gibson. These are folks, Michael J. Fox, of course, have Parkinson's, and their stories often bring us hope as we watch them cope with their own response to this disease. There's no cure for it, but there are lots of ways to overcome it and to keep whole even as the body continues to fight the disease. Today, I want to talk to the Director of Rehabilitation at the Good Shepherd Communities, Dr. Lane Duger. We're going to be talking about ways that we can help people look at the glass being half full instead of half empty. So let's begin. What led you into your interest in Parkinson's as a rehabilitation person?
Well, it can be very frustrating for the patient, of course, but also as from the clinical standpoint of trying to progress somebody from a debilitating disease and to either slow it or recover function. So, and because they're, the prevalence, you're going to see them frequently. Yeah. Maybe not every day, but you'll see a few of them every year for sure. So they're going to be on your caseload. So it just makes sense to try to find strategies that actually work, that are meaningful, and to recover function.
Almost all of us know someone with Parkinson's, and some of our viewers and listeners perhaps have Parkinson's disease and are already coping with it in various ways. What do we know what causes Parkinson's disease?
Well, I don't know that we know for sure what causes it, but we know, or at least we think we know, some of the biological aspects of it. And so there's a neurotransmitter, dopamine, that is made naturally in the brain, but then with Parkinson's, the ability to manufacture that decreases significantly to the point where it starts to affect motor function. And that's all motor function. It can be, speech, movement, strength, transfers, walking, balance, etc. So, we're pretty sure that it, is affected in the substantia nigra, which is a particular part of the brain. So that part we know. There are pharmacological strategies which are somewhat effective, but not completely effective because of the blood-brain barrier that envelops the brain, which is a protective membrane that keeps bad things out, bacteria, infections, and things like that. But when pharmacists try to create a medication that will be effective, at least in theory. The problem has been so far is that the size of the molecule is too big to pass through the blood-brain barrier. So that's, one of the limitations as far as chemical medicine goes.
Sure.
Yeah.
So there are, once again, looking at the disease itself, there are some environmental issues involved, or is this more genetic?
Well, there are theories about both.
Okay.
Yeah, there are theories. I don't know that anything has been particularly proven, but,
Right.
And it's probably a combination.
And the first thing that most people notice probably is a tremor. Would that be the first symptom?
Yeah, and probably only on one side.
Okay.
So like stage 1, very, very minimal, just some resting tremors
Yeah.
that would go away if you try to reach for something. And it would be mild, but they would probably be only on one side, and it wouldn't impact function in any way. You would just notice a tremor.
Right.
Now, not all tremors are Parkinson's.
Yes.
So I want to, I don't want to scare people that.
Sure.
Yeah, because too much caffeine can give you tremors.
Yeah. And often when people see, I remember many years ago when Dr. Marcus Welby was on television, they would deal with the disease, and the next day people were calling up their doctor saying, I think I have this disease. So as we talk, we want to be very clear that that we're talking about this is a personal experience for you working with Parkinson's patients, and we're not trying to be Dr. Radio here.
Absolutely. But that would probably be the first thing that they would notice, because that'd be a visual.
Yeah.
Yep.
And as it progresses, it takes a while, doesn't it?
Yes, and it's not the same in all people. So, but it is what I would consider a slowly progressing disease.
Yeah.
And so basically what would happen is it would worsen, of course, but to the point where it would cross over, so it would be on both sides of the body, but still be functional.
Yeah.
But you would have perhaps resting tremors in the hands. It could also be the feet, but probably the most noticeable would be the hands, fingers. But it would cross over to be, bilaterally, both sides. You'd still be able to be functional. You would still have balance. But then, as it progressed, you'd start to notice that you couldn't do things as well. So other things would become more pronounced. Difficulty standing up. Friends and family may notice a decrease in volume of speech. Decrease in speed of movements, accuracy of movements. The patient typically does not notice that.
Yeah.
Yeah.
And then there's this mask that I've
That
read
comes
about.
later, yes. Yeah. That's later on in like stage 3 or 4.
What does that mean?
Basically what that is as the disease progresses and motor function decreases, there's a lot of motor function in the face, a lot of muscles in the face that give expression, chewing, speech, etc. So when those are affected, then expression, the ability to express through facial expressions, decreases also. So therefore, that's where that mask comes on. It just basically, the face doesn't seem to move.
Yeah.
Even with the lips, with speech, very little movement. Volume goes way down. Yep. In fact, the drooling starts.
Yeah.
Yep.
So this is when the disease has progressed, but when someone is diagnosed with Parkinson's disease, what is your suggestion about how you begin coping with it? What are our coping strategies early on?
Well, they would probably start specifically with the MD, the physician that diagnosed. And typically they should be able to start the patient with some groups, like the organization, Parkinson's organization. Those are pretty simple to find nowadays with Google, with Google, etc. Yeah. And then even on the local level, they could find chapters there. Yep.
And that gives you a sense that you're not facing this alone.
Correct. So it would not only support the patient, but also family members.
Sure.
Yep. because they need education too, because they don't know exactly what they're up against. And
And then are there dietary strategies? You've already mentioned the drugs and
possibly, but I mean, at this moment, I would say that they would be related to any type of contraindication that would conflict with medications. And typically, Parkinson's patients can be on other medications too, that might have something to do with other things that they're dealing with, and they may have restrictions. So, but outside of that, obviously they would want something that they could chew and swallow safely, and those would be more, into the progression stage 3 or 4.
Right.
But yeah.
We're talking with Dr. Lane Duger, who is the Director of Rehabilitation at Good Shepherd Communities, about Parkinson's. Is this a specialty of yours?
Well, I'm certified
Okay.
in a particular program that addresses Parkinson's specifically for Parkinson's patients to recover function.
And you're working in a community of, pardon the expression, elderly people.
Older adults.
Yeah, who are older adults. Yeah,
Yes.
I am an older adult. But this is a disease that strikes people, can strike early on, but for the most part it's after 50, and then certainly after 60 is another
Yep,
place.
Typically, yes.
Yeah. And at that point in life, we are fragile and we feel more vulnerable, and so we need all the support we can find. And certainly for a religious community to be aware of ways that they can help, providing space for support groups, for example, or just being aware of the need to visit and to be supportive one-on-one with people is important. But there are other things. Now, this LSVT, loud and big, that was something I read briefly about, and something that came out from the Good Shepherd Villages. So let's talk a little bit about LSVT. You want to start with loud or big? I don't know where we're going.
Well, we'll start with big, but LSVT stands for Lee Silverman Voice Treatment, and that's basically where it all started. And it started with the loud, so it was really started with the speech component and developing strategies to increase speech quality, speech volume. So there are very specific protocols for speech, and there was a lot of research. This has been, we're somewhere around 25 years old now with this LSVT program. And many, many years of supporting research and progressing the LSVT protocol. So it started with the loud, but then because Parkinson's doesn't just affect speech, they started looking at applying the theory and the strategies to other parts of the bodies, and that's where the LSVT big came from. So loud specifically is really about exactly what it says, being able to speak very loudly, which to us would be normal, but to them, if they try to speak, or Parkinson's patients, many of them, if they try to speak as loud as us, they think that that's crazy. That is so not normal.
Shouting.
To them. So progressing from loud into big is where the physical therapy component and an occupational therapy component, or the combination, depending on what the patient really needs, was born, and research progressed with that. So certain specific protocols to improve function, flexibility, mobility, from getting in and out of bed, walking, standing up, sitting down, pulling keys out of your pocket, shaking somebody's hand, writing.
So with the loud aspect of the voice, this is pushing further than you normally would.
Well, for them.
Yeah, for them.
So basically what happens in Parkinson's is these people, the patients, they actually kind of recalibrate themselves. So they trend down. It's called scaling, so they scale down. Now, older adults scale down. That's very common, right? Because of life, mostly. It's not because of age, like everybody thinks. That's ageism. That's what ageism is. Yeah. They think just because you're 80, then, well, what do you expect? They're 80.
Yeah.
They can't do this and they can't do that. Well, 80-year-olds are actually running marathons.
Yeah.
So it really can't be the age, the number.
Yeah.
Well, it's basically what happens throughout life. You know, when you're youthful, you're playing high school sports or something. You're being active. And then, you know, after that, you go to college, you have more responsibilities, you get a job, so you have less time for that. And you get married and you have kids, and you really have less time to do those things. So we really start to trend down what we do, and that's more influential on our physical capabilities than just age alone. Right? Age does have a factor for sure, but it's more of what we do or basically what we don't do, however you want to look at it.
Yeah.
But in Parkinson's, it goes much further. So the brain creates less dopamine, which is a neurotransmitter that allows, it's just like a circuit. So it takes the message from one synapse over to another in a nerve, and the nerve basically carries a message. So when that chemical transmitter isn't there, that message doesn't cross. Yeah. And therefore, the phone lines are fine, but nobody's talking on the phone. Yeah. So the messages don't make it to the muscles. And there are other aspects of Parkinson's that like stiffness and rigidity and things like that. But basically, the brain starts to recognize this as being more normal, so it scales down. So it doesn't realize that you're taking really, really small steps, or your writing is really, really, really small, or your voice production is really, really low. So basically, all your movements, even small movements, are really way too small in Parkinson's. So we say that there's bradykinesia, and that's slowness of movement. And then hypokinesia, not enough. So everything gets really, really small. And that's very problematic.
So when you move to LSVT big, I want to try to make the analogy here with the voice where you're helping people speak more loudly, and big is that to